Okay, Assalamu alaikum everyone. My name is Nawaal Saleem. I'm a third year medical student, and today we're going to be talking about control of cardiac output. So let me pull out the slides and we can get started. Um, let's put I always struggle with these things. Okay. Awesome. Okay. So we're going to talk about control of cardiac output 1 and 2. And this is a very confusing lecture for a lot of people. So I would suggest that you guys please concentrate, especially towards the latter part where we have some graphs. If you have any questions at all, please do not hesitate to email me. This is my email. Okay, so let's get started. Bismillah. This is a table of contents. So for nervous regulation, we have the rapid control of arterial pressure. So we have the control of the rapid control of arterial pressure through the baroreceptors, the chemoreceptors, the atria and the lungs, the kidneys, the brain, which has something called the Cushing reaction. There's some special features of the nervous control of arterial pressure that you need to know. Know about what factors affect tissue blood flow, vasodilator and oxygen demand theories, mechanisms of autoregulation, and know how various humoral factors affect blood flow. That was a mouthful. You're gonna know what all these mean, so don't worry, this is just a table of contents, okay? So the brain is primarily involved in changing the blood pressure, okay? And if it's just the brain, the response is going to be rapid and acute. It's going to take seconds. However, if kidneys are involved in blood pressure control, it's going to be long term because, of course, you have all these hormones, endocrine factors, all these things. Those are going to take a long time, okay? So kidneys are involved in long-term BP control. This is very, very important equation that we're gonna repeat a lot of the times in this PAL session. So we have mean arterial pressure equals to cardiac output into total peripheral resistance. So mean arterial pressure is basically the total pressure in all of the arteries. Okay. Cardiac output is the definition is heart rate into stroke volume, but you don't need to know that right now. It's basically the total amount of blood pumped per minute, and total peripheral resistance is all the resistance in your peripheral vessels. Okay, so that is the total peripheral resistance. Memorize this equation right now. So let's talk about some implications of this. Suppose we have a mean arterial pressure, okay? What happens if we increase the cardiac output? Okay, of course, the mean arterial pressure is going to increase. How is that? So you have the heart, okay? And if it contracts harder, if the contractility, if it increases, the force increases, it's going to eject more blood into the blood vessels. So it's going to contract very forcefully. All the blood is going to go in the arteries, okay? That is going to increase the mean arterial pressure. It's going to increase the blood pressure inside the arteries, okay? What happens if you increase the total peripheral resistance? Okay. Mean arterial pressure is going to increase because this is so this is the arteries. Okay. If they're going to vasoconstrict, if the diameter is decreased, the resistance of these vessels is going to increase. That means all the blood pressure over here is accumulated. Okay, so imagine you have a lot of blood and then you're going to squeeze on it. Okay, that is going to cause an increased pressure inside the artery. That's going to increase the mean arterial pressure. Okay, I hope this is clear. This is just a written format, constricting almost all arterioles of the body, which increases total peripheral resistance. So remember, if you are going to be changing total peripheral resistance, the things that are contracting are actually arterioles, okay? Constricting large vessels of the circulation, thereby increasing venous return and cardiac output. So if you look over here, you have a lot of blood vessels, right? This is the whole circulatory system. If you zoom in over here, this vena cava is going up and it's going into the heart, okay? So if you constrict the vena cava from the bottom, the blood has nowhere to go except up. So it goes up and it goes into the heart, okay? The heart is going to fill up with blood, so it's going to be full of blood. And what does it have to do? It has to contract because it's not going to keep the blood inside. It's going to contract, and therefore cardiac output would also increase. So if you increase the vena cava, if you compress the vena cava, if you increase the pressure inside it, all the blood is going to go into the heart. The heart is going to contract, and that is going to increase the cardiac output. Okay, and when cardiac output increases, all the blood goes into the arteries, so the mean arterial pressure will increase. Okay? Directly increasing cardiac output by increasing heart rate and contractility. That just means that if the heart pumps faster or with more force, the cardiac output will increase. This is another slide. Okay, so BP control is very important. Why are we talking about all this? Is because we have to maintain the blood pressure. Because if you have too much of a high blood pressure, it's going to damage your artery. It's going to damage your veins, your capillaries. All the delicate vasculature is going to be damaged. If you have too less of a BP, if there's very little blood flowing, the tissues that need oxygen are not going to get an adequate blood supply. So that is why it's very important that you have it in the normal range of 120/80. Okay. Now let's talk about the control. Over here you have a negative feedback loop. Okay, and that includes a stimulus, a sensor, a control, and an effector. Now the stimulus is a high or low BP. So you're sitting and you have a normal BP. Suddenly your BP goes up. Okay, that is the stimulus. What is going to sense that BP going up? There's something called a baroreceptor. Baro meaning pressure, receptor meaning they're going to recept. So baroreceptor is going to sense that high BP. Okay, so now that if you sense it, what happens? Okay, who's going to decide what to do? So the control part is done by the nucleus tractus solitarius in the brain. It is going to decide, okay, it's sensing the high blood pressure. It's thinking, okay, what do I do now? So whatever it decides to do, it's going to send it to the effector. So the effector are the heart and blood vessels. This is where they're going to take effect. Okay? So then you have the baroreceptors. You have a high pressure, okay, and a low pressure. So in the high pressure areas, you have, okay, you can't really see these properly, but high pressure baroreceptors are present in the aortic arch and they're present in the carotid sinus. Okay, aortic arch is basically you have the heart and then the aorta comes out and it arches like this. This is the area where you find baroreceptors. And then you have carotids over here in your neck. And right before the common carotid bifurcates, there is the baroreceptor area. Okay. And there's also high pressure baroreceptors in the kidney, in the afferent arteriole. Low pressure baroreceptors are found in the vena cava, right atrium, and pulmonary artery. This is the right side of the heart. The right side of the heart is normally low pressure, okay? That is why they're called low pressure baroreceptors. The function is exactly the same, it's just that they're located in the low pressure areas. So baroreceptors activated by high BP. So in the aortic arch, we said that they are baroreceptors, right? So the nerve that's going to carry information from these baroreceptors in the aortic arch is the vagus nerve, okay? In the carotid, it's the Herring's nerve. So you look over here, this is the carotid sinus. These are the baroreceptor receptors. And the Herring's nerve is going up, 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 and it's joining the glossopharyngeal nerve. So remember, vagus nerve for aortic arch, Herring's nerve for carotid. Okay? Now, in your body, there's always homeostasis. Okay? It's homeostasis between sympathetic and parasympathetic. In parasympathetic, it's rest and digest. Parasympathetic means that you are calm and you are relaxed. So think about it. When you're calm and when you're relaxed, your blood pressure is low. Your heart rate is low. You're very relaxed. The heart is relaxed. Everything is normal. Okay? And that is when you're resting and digesting. However, if I'm sitting over here and I see a monster over there, I'm going to get scared. My heart rate is going to go up and my sympathetic response is going to activate. So the parasympathetic response over here is reducing your BP. Sympathetic response is increasing your BP. And how does it do that? It's going to make the heart contract faster and harder, and it's going to constrict the blood vessels to make the blood flow, okay, and to increase resistance. So always remember that it's not the case that if one is, for example, if you're in sympathetic mode, it doesn't mean that parasympathetic is completely stopped. Okay, there's always a minimal firing rate. There's always homeostasis between the two. Again, sympathetic versus parasympathetic. In sympathetic, you have increased heart rate. The sympathetic nervous system, keep in mind, acts on both the heart and the blood vessels. Okay, so it's going to increase the heart rate. It's going to constrict the blood vessels. Okay, and that can raise the BP by 2 times in 5 to 10 seconds, very quickly. Parasympathetic its job is to calm everything down. It's going to decrease the cardiac output, decrease the heart, and your BP can half in 10 to 40 seconds. Okay. Okay, so let's get to the thick of it. If BP is too high, I'm sitting here. Okay, I'm calm, I'm relaxed. Again, I see a monster. I'm scared. I'm so scared. My blood pressure is going up. The blood is coursing through my arteries. So that means that you have increased mechanical stimulation of baroreceptors because blood is a physical entity, right? It's going to stretch the walls of the arteries, and that is going to mechanically stimulate these baroreceptors. So the baroreceptor firing increases. They're like, oh my God, what's going on? Why are we getting activated? The nucleus solitarius in the brain is going to wake up. It's going to be like, whoa, what's going on? Why is there so much firing? And then it wakes up a secondary mechanism, and that secondary mechanism is going to make a decision. Okay, so it looks at everything. It's like, okay, the baroreceptor firing is increased, the blood pressure is high. What can I do to make it low again? The goal over here is to decrease the blood pressure. Okay, so what it's going to do is that it's going to inhibit the sympathetics. Okay, it's going to inhibit the vasoconstrictor center. That means your blood vessels will dilate. So if your blood pressure is increased, your vessels are going to dilate so that all of that blood can go and everything can calm down. On the other hand, your parasympathetic system is excited. So what that parasympathetic system does is that it decreases the heart rate and increases the contractility of the heart. Okay? Sorry, it decreases the heart rate and decreases both the contractility. So again, if sympathetic system is inhibited, okay, that means that there is no vasoconstriction and the contractility of the heart, it's not contracting as hard. Okay, it's very, very little contractions. Everything is slowing down. So if BP is too high, sympathetic inhibited, parasympathetic excited. Okay. And what happens if BP is too low? Okay. So I'm sitting down and I'm sitting and I'm sitting and I'm sitting for hours and my blood pressure is going down. Okay. And then the baroreceptor they're not firing because there's no mechanical stimulation. It's very little mechanical stimulation because there's very little blood flow. So the baroreceptor firing is going to decrease. The nucleus solitarius is also asleep. Okay, everything is way too calm. And the secondary mechanism in the brain realizes it's it's too quiet. Okay. And it wants to wake everything up because if your BP is too low, you're gonna die. Okay. So the brain activates the sympathetic system. Okay. The sympathetic system is going to make the heart contract faster and harder and so to constrict the blood vessels. That means that everything is going to get excited. That means your BP will return to normal because it will increase. Your parasympathetics in this case are inhibited because you're already relaxing. You don't need any more of the relaxation. I hope this is clear. This is a very important concept, okay? So again, if BP is too high, sympathetics are inhibited. And if BP is too high, parasympathetic system is excited. If BP is too low, sympathetic system is excited. And if BP is too low, sympathetic system is excited. Both sides. Okay, so for both heart and for vessels. Okay, so let's talk about this very, very confusing thing here. Because according to the slides, I was reading the slides and in the transcription, it said that doctor says that a lot of students confuse this thing, okay? So if you have more stretch, you have less sympathetic activation. If you have less stretch, you have more sympathetic activation. Why? Because in the case of less stretch over here, particularly if you look, the baroreceptors are not firing at all. That means that if you don't do anything, your blood pressure is going to drop like crazy. That is why you need to activate it. You need to increase the blood pressure. And how do you increase blood pressure? You activate the sympathetic system. Sympathetic system is going to contract the heart hard and fast, and it's going to vasoconstrict. So the blood pressure is going to increase. This is very important. Please try to understand. Now, question. While participating in a cardiovascular physiology lab, a medical student isolates an animal's carotid artery proximal to the carotid bifurcation and partially constricts the artery with a tie around the vessel. Which set of changes would be expected to occur in response to constriction of the carotid artery? Okay, let me explain the question. So this is the carotid artery, okay, and it's going to bifurcate like this. The baroreceptors are located over here. Remember, if you tie the vessel from here, that means the blood cannot go past this occlusion. Less blood is flowing to the baroreceptors. Now think about it. If there's less blood flow to the baroreceptors, what's going to happen? Pause and answer. Okay? So if the baroreceptors are not activated, okay, that means the BP is too low. If the BP is too low, the brain is going to sense the low BP. It's going to activate the sympathetics. So your heart rate will go up, parasympathetic nerve activity will go down, and total peripheral resistance will increase. So the answer is D. Now, baroreceptors act as buffers. So they did an experiment. Scientists, they took two dogs. In one dog, the baroreceptors are normal. In the second dog, the baroreceptors are denervated, means they're not working. Okay? So in the first dog, you can see that the blood pressure is fluctuating normally. So it's like 120/80. It's normal. But in the dog where you remove the baroreceptors, the blood pressure, it's crazy. It's going up and down, up and down, up and down, up and down. It's like 180, it's reaching 200. So what I mean to say is that the fluctuations are crazy. And if you have such fluctuations, it's going to cause either damage because of high blood pressure or ischemia because it's very, very low blood pressure. And what you want to do is that you want to keep it in a range. You don't want all these large BP swings. And that is why baroreceptors act as buffers of this system. Okay. So let's read this table together. With the baroreceptor reflex, you have small BP fluctuations, stable organ perfusion, rapid automatic correction. Without the baroreceptors, you have large BP swings, risk of ischemia because of low blood pressure, and vessel damage because of high blood pressure. And you have loss of short-term control. Now, baroreceptors reset at maintained arterial pressure that they are exposed to for long durations. Okay? So the abnormal one becomes a new normal after 1 to 2 days. If you have a blood pressure of 120/80, it is normal. But God forbid, in a person with chronic hypertension or with someone who's experiencing early hypertensive symptoms, if his blood pressure increases to, for example, 140/60, okay, and this blood pressure remains 140/60 for 1 to 2 days, the receptors are going to keep sensing this and they're going to adapt to this. So this will become the new normal, when this shouldn't be the case because this is abnormal. And is this reversible? Yes, it is. If you want to reverse this hypertension, you're going to have to keep it at a normal 120/80 for 1 to 2 days. It will turn back to normal. Okay? Now, apart from baroreceptors, which are for pressure, you also have chemoreceptors. Chemo meaning chemical. These chemoreceptors are, you can see it almost the same place as the baroreceptors. So aortic arch and over here at the bifurcation. And they are supplied by the nutrient arteries. Okay, and they're activated by low oxygen, high CO2, and high pH. How does this happen? Now, if the blood pressure drops below 80, okay, blood is not flowing properly through these vessels. That means that the cells around, whatever they're metabolizing stuff and whatever they're doing, whatever their products excreting, okay, they're metabolizing. Okay, so let me reword this. You have cells in these areas, okay? They're going about their normal metabolic processes. The products of these metabolic processes are going to accumulate in the blood vessel, okay? Normally, if you have 120/80, it's going to wash out these toxins away, so there will be no toxicity. If your blood pressure drops, that means there's no blood to wash away these toxins. And so chemoreceptors are going to be activated. They're going to sense all of this imbalance. They're going to sense the low oxygen, high CO2, high pH. They're going to be like, whoa, what's going on? Why isn't the blood coming and washing everything away? And they're going to activate the sympathetic and inhibit parasympathetic. This is going to increase the BP and it's going to restore blood flow. Okay? So for low pressure baroreceptors, again, these are exactly the same as high pressure baroreceptors, except that they're located in low pressure areas of the body, which are the atria, the pulmonary arteries, the right side of the heart. Okay. Now, an increase in blood volume or venous return, such as during inspiration or after IV fluid infusion, that is going to stretch the right atrium. Okay. So when you are inspiring, there is going to be increased venous return to the heart. What that means is that if this is the right atrium and this is the vena cava, if you inspire, more of the blood is going to flow into the right atrium. And when there's more blood in the right atrium is going to expand. Okay? After IV fluid infusion, if you take a person and you put a lot of IV fluid into him or her, that is going to increase the amount of blood in the vessels. And at the end, all of the blood has to go where? Into the heart. So all of the blood is going to go into the right atrium. The right atrium is going to expand, okay? And that is going to activate what we call the Bainbridge reflex. So again, increased venous return, so increased blood flowing from the vena cava into the right atrium. The atrial stretch is going to stimulate the receptors. The impulses are sent up. So sympathetic is activated and parasympathetic is inhibited. Why? Because if you have a lot of blood in the right atrium and you have a lot of blood in the heart, and the heart is not going to hog up all the blood, it has to get rid of the blood. So that is why it is going to contract. The heart rate is going to increase. So it's going to keep contracting to get rid of all of this blood. Okay, I hope that's clear. If you have any questions, again, please do not hesitate to contact me. This is very, very important topic. Again, the kidneys. If increased blood pressure, atria stretch. Now, we said that if the atria stretch, they're going to activate the sympathetics and inhibit parasympathetics. Apart from that, there's also going to be an influence on the kidneys, okay? Because when you have increased blood pressure, the hypothalamus is inhibited. It will not secrete ADH, okay? So ADH is not secreted. That means that water is lost through the kidneys. So you have less volume of fluid, which decreases the BP, okay? If you have decreased blood pressure, the sympathetics are activated. So when I'm sitting down, I have very low blood pressure. The sympathetic is going to activate. So sympathetic is going to act on the heart. It's going to increase the heart rates, increase the contractility. It's going to vasoconstrict my blood vessels, but also it's going to act on the kidneys. As a result of this sympathetic activation, the kidneys are going to retain water and salt. So the water will not be lost. It's going to stay in the body because you already have a low blood pressure and you don't want this water to be lost as urine. You want to keep it in the body. So that is why when they retain water and salt, the blood volume is going to increase and you are going to have an increased BP. Special features in which the heart rate is going to increase. So you have two. You have muscle contraction and you have breathing. And this is a special case, which is orthostatic hypertension. So in muscle contraction, when I'm sitting down, okay, and I'm going to compress on my abdomen, when I compress, my muscles are going to be compressed, right? The muscles, when they're compressed, are going to also compress the vena cava, okay? It's going to compress all the large veins. So when you compress the large veins, the blood has to go up. It cannot go anywhere else. So if I constrict, if I press on the blood vessel, it's going to go up into the heart. Into the heart means more blood is going to the heart, which means increased venous return. Increased venous return, we just said that it's going to increase the cardiac output because the heart is going to contract. For breathing, if I breathe, I also have increased venous return. For orthostatic hypertension, so if somebody's laying down, okay, they're comfortable, very comfortable, then they suddenly stand up, okay? All the blood is going to pool into their legs because of gravity. When that happens, the baroreceptor firing is going to decrease because the blood is going down, it's not up anymore. And then there's less blood going through your aortic arch, there's less blood going through your carotids. The mechanical stimulation of the baroreceptor is less, baroreceptor firing is less. And then the brain realizes, oh no, low blood pressure, and the sympathetics are stimulated, okay? And that's going to increase the heart rates. Ischemic response. This is a clinical case, low-key. If blood pressure falls below 60, okay, remember 120 over 80 is normal. If it falls below 60, that means that the brain is in danger. The brain needs almost like 14% of the cardiac output. It needs a lot of blood. If it falls below 60, you're going to have ischemia of the brain. And that is like a crazy situation. It's also called the last ditch stand response. And what that happens is that you have a crazy sympathetic stimulation by the brain. You have a vasoconstrictor and cardiac accelerator, which means that, again, if you remember the equation, mean arterial pressure, mean arterial pressure equals to cardiac output into total peripheral resistance, okay? If the mean arterial pressure drops below 60, you need to increase cardiac output, and you need to increase total peripheral resistance to make this thing come back up. Otherwise, you're going to lose your brain. So the vasoconstrictor, so total peripheral resistance is going to increase, and cardiac accelerator, which means the cardiac output is going to increase. These responses are activated, and your mean arterial pressure is like a last desperate attempt by your body to bring up the arterial pressure and perfuse your brain. Okay. Now, clinically, what could cause an ischemic response like this? Your brain is surrounded by cerebrospinal fluid. Okay. If in any case the cerebrospinal fluid increases, that is going to compress your brain. It's going to compress the arteries leading up to the brain. And when that happens, the blood supply is low-key, it's cut off. And that means the brain realizes, oh no, I'm going to go into ischemia. And it's going to activate the sympathetics again. So you're going to have increased cardiac output and vasoconstriction. Alhamdulillah, we're done with BP control, like the systemic one. Now we have to talk about local control. So variations in tissue blood flow. Okay, yeah. So the cardiac output is 100%. Okay, so remember that whatever blood is going out of the heart is 100%. 14% of that blood is going to the brain, 4% to the heart, 2% to the bronchi, 22% to the kidneys, 27% to the liver, so on and so forth. Okay, the total is 100. So the heart cannot give all its blood to all the tissues. Okay, it needs to prioritize according to demand. What that means is that if I am exercising, my muscles need more blood than my stomach because I'm exercising, I'm running. I'm running with my legs and my muscles, not my stomach. So the blood flow to my muscles is going to increase, and my blood flow to my stomach is going to decrease. Okay? And that is achieved by local blood flow mechanisms. The acute control is achieved by vasodilation or vasoconstriction of arterioles, meta-arterioles, and precapillary sphincters. So it's always arterioles, meta-arterioles, or precapillary sphincters, never capillaries, because capillaries don't have smooth muscle. Long-term control. This is over a period of days, weeks, or even months. So if I go to the gym very regularly, my muscle mass is going to increase. And when my muscle mass is going to increase, I'm going to have more blood vessels supplying my muscles because they need that. It's going to cause angiogenesis, and that is long-term control. Now let's talk about autoregulation of blood flow. Autoregulation is the ability of an organ to maintain a constant blood flow even when arterial pressure changes. Okay? So regardless of whatever is going on in the aorta and in the big arteries, an organ has the ability to maintain its own blood flow. Okay? And that is achieved by either myogenic theory or metabolic theory. In myogenic theory, again, note myo means muscle. The smooth muscle is going to contract and relax. Or you have something called nitric oxide. In metabolic theory, you have metabolites, which are the product of metabolism in cells. These are going to regulate blood flow, or peregrine agents, which are going to regulate blood flow. So myogenic theory, also called the myogenic reflex, is a protective mechanism where smooth muscle cells are going to contract reflexly when stretched excessively. Okay, so suppose I am an organ. Blood flow, like I sense a lot of blood flow coming towards me. And if all of this blood flow comes at once to me as an organ, I'm going to get damaged because I cannot tolerate all of this. So in front of me, of course, the blood is going to come through arteries, right? But then before it reaches me, I have arterioles. So when they notice this huge pressure coming up, they're going to stretch to accommodate. But then that stretch is going to depolarize the smooth muscle in the arterioles. And when that thing depolarizes, it's going to contract. Okay, because remember, skeletal muscles and smooth muscles, when you have depolarization, it's going to cause contraction. So blood pressure, stretch, the stretch is going to cause depolarization, and then depolarization is going to cause vasoconstriction. So the arterioles are going to vasoconstrict so that less of this damaging blood flow reaches me as the organ. And that is how you decrease flow. Yeah. This is the high blood pressure, it's coming. Okay. The arterioles are going to sense this. They're going to stretch. Stretch is going to cause depolarization, and they're going to vasoconstrict so that less blood is going to reach the organ because you don't need all that. It's going to damage the organ. Next, this is the myogenic reflex in detail. So you have increased intraluminal pressure. So you can see increased BP here. Stretch-induced smooth muscle depolarization. So stretch, it's going to cause depolarization. It's going to open voltage-gated calcium channels. And then MLCP phosphorylation, that's going to cause contraction. So basically, all that means is that increased BP, arterioles are going to stretch, depolarization, constrict. So it's going to cause vasoconstriction, and the organ is protected from the high BP. Phew. Okay. In the same myogenic theory, you also have nitric oxide. Okay. This nitric oxide is actually formed by endothelial cells, and it is a vasodilator. So wherever nitric oxide flows to, it's going to cause dilation of the blood vessels. And it is always produced in response to shear stress. This is a key word, okay? Now, if you look at this diagram over here, there is shear stress, right? That is going to cause the formation of nitric oxide. Nitric oxide is going to go into the smooth muscle cell. It's going to make this cyclic GTP convert to cyclic GMP, cyclic guanylyl monophosphate. So cGMP, in essence, is what causes relaxation, okay? This is a clinical application. So for patients with sexual dysfunction, they can't maintain an erection, okay? And remember that nitric oxide is a vasodilator, and you want more of this nitric oxide in these patients. So there's an active ingredient called sildenafil, which is found in Viagra, and it causes degradation of cGMP by, it stops degradation of cGMP by PDE5. Because remember here, that cGMP is the one that causes relaxation. If this is broken down, it's going to stop. Relaxation is going to stop. It's going to constrict again. So you want to maintain the relaxation, which means that you want to maintain increased levels of cGMP. And whatever enzyme is coming to inhibit cGMP, it's going to block that reaction. So you have prolonged effect of nitric oxide. Now, in patients with chronic hypertension, what happens is that if you have a blood vessel and you have a lot of hypertension for a long time, blood is flowing, it's going to damage the endothelial cells. When endothelial cells are damaged, they can't make nitric oxide, and that's going to cause excessive constriction, and that's going to worsen everything. Okay? Now, in metabolic theory of blood flow regulation, the metabolites, the byproducts are vasodilators. So if you break down ATP for energy, you're going to get adenosine, lactate, hydrogen ions, potassium ions, low oxygen, high carbon dioxide. These are all vasodilators. For paracrine, you have histamine. Remember that oxygen itself is not a vasodilator. It's just the levels of oxygen and carbon dioxide. So what happens if arterial pressure increases? Okay. Remember that all of these are vasodilators. So when arterial pressure increases, blood flow is going to increase. So all these vasodilators are just chilling, okay? And the blood vessel is vasodilated. If arterial pressure increases suddenly, all the blood is going to go, it's going to push those vasodilators out of circulation. So the vasodilators are going to be washed away. Their concentration will fall. If their concentration falls, vasodilators are gone, right? Their concentration falls, you have vasoconstriction. So this constriction reduces the flow back towards normal. If arterial pressure decreases, okay, if you have reduced flow, okay, so vasodilators are chilling and the blood flow is reduced, okay, it's going. So the vasodilators are there and it's just reduced. Like there is no blood to wash away these vasodilators. So they're just going to cause expansion. So as they're causing the expansion, of course, more blood is going to come in. So if arterial pressure decreases, you have reduced flow and metabolites are going to accumulate. However, it's going to get to a point because all of these vasodilators are going to cause vasodilation. And vasodilation means more blood is going to come in eventually. So this is autoregulation, okay? So you have lactate, adenosine, potassium, hydrogen, increased CO2, decreased O2, nitric oxide, histamine, bradykinin. Okay, this is just a visual. So you have vasodilators, you have increased arterial pressure. It's going to wipe those away. They're gone now. and that's going to cause vasoconstriction. This is a very important disease. You have wet beriberi disease. So under special conditions like low glucose, low amino acids, or vitamin B deficiency, and very specifically, you have lack of thiamine, niacin, and riboflavin, the peripheral blood flow is increased 2 to 3 folds. Now, why is that? Okay. I have this written down very nicely. So a lack of thiamine is going to disrupt key enzymes in the Krebs cycle. Um, okay. Put that there so I can see what's going on. Okay, so a lack of thiamine disrupts key enzymes in the Krebs cycle. And when the Krebs cycle is disrupted, that means aerobic respiration is disrupted. And that means you have less ATP production. So look over here, less ATP production. So even if you increase oxygen delivery to these tissues, it's not going to help because the problem is not with oxygen delivery, it's with the enzymes in the Krebs cycle. So you have less ATP production. And when you have less ATP production, that means the smooth muscles cannot contract. Okay? So whatever arterioles you have in all of the body, they're not going to contract, they're all going to dilate. And when they're all going to dilate, that's going to cause massive peripheral vasodilation. So what that means is that all the blood is going to pool up in the peripherals. And because of the vasodilation, you have decreased peripheral resistance. Okay? Now think about it for a moment. If your blood vessels can't constrict, if your arterioles, if there's no constriction of the levels of the arterioles, all the blood is pooling down. Okay? Now think about this equation again, one more time. Mean arterial pressure equals to cardiac outputs into TPR. Mean arterial pressure is something that you want to maintain at a level of X, for example. If total peripheral resistance is massively decreased, okay, that means to maintain a mean arterial pressure, you have to massively increase the cardiac output. That means the heart has to work harder and faster to maintain perfusion of tissues in the body, and that is going to cause a high output cardiac failure. Very important disease. Again, this is just autoregulation. So if the blood pressure is ranging from 180 to 60, the organs have this ability to regulate a constant flow towards themselves. And this is especially important in hemorrhage and hypertension. In hemorrhage, you have loss of blood. In hypertension, you have a lot of problems, basically. So autoregulation is very important here. And the goal is to maintain adequate perfusion and prevent damage to vasculature. Okay, this is just reading for you. Active hyperemia and reactive hyperemia. In active hyperemia, you have increased blood flow due to an increase in metabolism. It's also called the functional or exercise hyperemia. So when you're exercising, you're working out, your cells are using up a lot more oxygen and they're producing a lot more carbon dioxide and other metabolites. And all of these, remember, metabolites are vasodilators and they're going to cause vasodilation. Okay, so when you're exercising, you're going to have vasodilation, and that is called active hyperemia. Simple. But remember this, the shape of this graph, it goes like, okay? This is another vasodilator theory for blood flow control. It's also called the oxygen demand theory. I think this is a keyword in your lectures, very important. So if you have decreased oxygen delivery or increased tissue metabolism, okay? So in the case of either like low BP or exercising, your tissue oxygen is going to increase because it's all being used up or it's not being delivered at all. And that is going to cause relaxation of arterioles and precapillary sphincters. And once these thingies are going to relax, these sphincters are going to relax, that means the blood vessel is going to dilate. That's going to cause increased tissue blood flow. Okay? And this cyclical opening and closing is called vasomotion. So it's cyclical. It's constriction, dilation, constriction, dilation, constriction, dilation, you know? So this is the oxygen demand theory. Reactive hyperemia occurs due to a temporary occlusion. Let me try to get in the frame. Okay. Now, if I take my arm, can you see my arm? Okay, now you can see my arm. So if I take my arm, okay, and occluded like this. Blood is not reaching my hands. Okay, so the cells in my hand are doing their regular metabolism, and all of the metabolites are accumulating. Okay, remember, metabolites are vasodilators. So not only are they accumulating, they're also vasodilating whatever there is inside they're vasodilating. So vasodilation is happening in my hands, okay? Once I remove this, all of the blood is going to increase like crazy because there's all these metabolites. And when you have metabolites, you have vasodilation. Okay, I hope you got that. Okay, so again, active hyperemia happens when you have an increase in metabolism because you're exercising. Okay, reactive hyperemia is when you have buildup of metabolic waste because there is temporary occlusion. No more blood is like, there's no blood to take all of those metabolites away because it's temporary occlusion. So remember the shape of this graph, it goes like this, like that, okay? This is the timings. So if I occlude for 30 seconds, the blood flow is going to increase a little bit. If I occlude for a minute, the reactive blood flow is higher. If it's 5 minutes, it's the highest because it was occluded for 5 minutes. All that metabolic waste, all those vasodilators are going to cause a higher increased blood flow. That is reactive hyperemia. This is the concept of the graph. It's very, very simple. And we also have a very good example. Coronary blood flow. Coronary vessels supply blood to the heart, okay? And they're controlled almost entirely by local factors. And you have both metabolic and myogenic control, okay? So in metabolic, you have active hyperemia. Why active hyperemia? Because the heart is always pumping, it's always working. And there's always use of ATP, it's going to produce adenosine, and hypoxia because it's like low O2, okay? So adenosine and hypoxia are going to cause active hyperemia because the oxygen is always being used up. Reactive hyperemia is compression of coronary arteries during contraction. So when the heart contracts, the coronary arteries are also going to be compressed for a bit. So that basically means that there's a temporary occlusion, okay? And that's going to cause reactive hyperemia. In myogenic control, nitric oxide is produced by shear stress. Look, shear stress again on the vessels. And again, nitric oxide is a local vasodilator. So it's going to dilate the coronary arteries. Question time. A healthy 27-year-old female medical student runs a 5-kilometer race, which is a lot. Which of these physiological changes is most likely to occur in this woman's skeletal muscles during the race? Pause and think. Okay, so the woman is exercising. Her muscles are moving a lot, okay? Now, when those muscles are moving, they're metabolizing waste. They're metabolizing whatever it is, and they're producing waste, right? And those metabolites are actually vasodilators. And those vasodilators are going to cause what? Active hyperemia. And in active hyperemia, remember, you have a decreased arteriolar resistance because hyperemia means increased blood flow. So you have increased blood flow because the arterioles are not contracted, they're dilated. So everything is just going, okay? Tissue pH is decreased. Why? Because remember, one of the metabolites was hydrogen ions. So when you have an increase in hydrogen ions, you're going to have a decrease in tissue pH. And you have tissue carbon dioxide, of course. If you're going to use up oxygen, it's going to produce carbon dioxide. So carbon dioxide is going to increase. So that is going to cause active hyperemia. Answer is F. Question time. Cognitive stimuli such as reading, problem solving, and talking all, I don't know what that word says, in significant increases. Hold on, let me just move my Zoom thingy. Here we go. Cognitive stimuli such as reading, problem solving, and talking all result in significant increases in cerebral blood flow. Which set of changes in cerebral tissue concentrations is the most likely explanation for the increase in cerebral blood flow? Now think about it. So the brain is using up oxygen. Okay, it's using up oxygen and it's producing carbon dioxide, right? So the carbon dioxide levels are going to increase. The brain is working, so it's producing metabolites. So hydrogen ions are increasing, pH is decreasing. One of the metabolites was adenosine, which is increasing. The answer is B. Unfortunately, you have to know all of these. That's straight. Okay. So unfortunately, you have to know all of these. Mm, okay. So the basic constrictors are norepinephrine and epinephrine. Angiotensin, vasopressin, endothelin, vasodilator agents are bradykinin, serotonin, histamine, blah, blah. Calcium is a vasoconstrictor, and the rest of these are all vasodilators. Remember this. And all of these are short-term acting. Now what happens if you have chronic changes in blood flow or pressure? So if somebody's going to the gym, okay, and they're building muscle, you're going to have angiogenesis to supply those muscles. So new blood vessels are going to form so that they can supply the increased muscle mass. And somebody who has chronic changes in blood pressure, for example, the diameter of those blood vessels may change, or the muscle mass of those blood vessels may change. So if the blood vessel needs to contract more, it might have hypertrophy. So just remember these: angiogenesis, change in diameter, and change in muscle mass. Okay, so now we're going to start the second part of the lecture after like a short 15-minute break. I hope that everything is clear. How do I pause? Okay. Mm, mhm, mm, Wait, okay. We are back. So let's talk about control of cardiac output too. Um, no, stop. Okay. So these are the session learning outcomes. So we have normal values for cardiac output at rest and during activity. Okay, so you have 5 liters per minute at rest and 20 to 23 during activity. Control of cardiac output by venous return and the Frank-Starling mechanism of the heart. Control of cardiac output by tissue metabolism, limit of the heart for the maximum cardiac output because the heart cannot go beyond its maximum capacity. You have role of the nervous system in controlling the cardiac output. You have the cardiac output curve and the venous return curve, and then both of them combined together. So normal cardiac output is 5 liters per minute. However, people come in different shapes and sizes. So we have something called a cardiac index, which normalizes this cardiac output to the rest of the population. So you have cardiac index equals to cardiac output over the total body surface area. So normally it's 5 liters per minute, and like the average body surface area for an adult is 1.7. So an average cardiac index would be around 3. It can range from 2.5 to like 4 liters per minute per meter squared. Okay. Cardiac index at different ages. Okay, so you can see it's a curve, and it's peaking at around, looks like 10 to me. Okay, so at the age of around 10 years, the cardiac index here is maximum. However, you can see as you get older, your cardiac index is decreasing. Why is that? Okay, so I want to write the equation like this, just to make it clearer. So you have cardiac index equals to cardiac output over body, oops, body surface area. Now, if you grow older, you might gain a lot of weight. And that means that your body surface area is going to increase. And that would mean that your cardiac index is going to decrease, as you can see here. Okay. Or if you grow up, a lot of people, when they're like in their 40s, 50s, they develop heart problems. And with those heart problems, their cardiac output might decrease. Okay. If the cardiac output decreases, that means the cardiac index will also decrease. So these are just some factors that can influence, like as people grow older, there's problems, they gain weight, they exercise less, they gain weight, things like that. So factors that directly affect cardiac output are metabolism, exercising, age, and body size. Now, this is very important, so please focus with me. This is the left side of the heart. Okay, so the left ventricle is going to pump the blood, it's going to go in the aorta, and that's like 100% of the cardiac output in the aorta. And then it's going to divide into the organs. So 14% of the cardiac output goes to the brain, 4% to the heart, 22% to kidneys, 15 and 18. Okay, so the sum of all of this is 100%. Okay. After it's done, after the blood is done going to the organs, it's going to combine into the venous return in the vena cava. Okay, so 100% divided after the organs, it's going to combine again to give you 100%. So whatever's leaving the left side of the heart, even if it splits, it's all going to come back combined as 100% again as venous return. So what that means is that whatever leaves the heart must come back to the heart. So cardiac output is the sum of all tissue flows, and venous return equals to cardiac output under normal condition. Remember this. So blood control may increase locally in some tissues, but it is always compensated by decrease in other tissues. So if during exercise, blood control increases blood pressure or blood flow actually increases the skeletal muscle, then blood flow to, for example, the stomach is going to decrease. Athletes use more oxygen and have a higher cardiac output. Okay. So if you look at this graph over here, the blue part represents oxygen consumption and the red part represents cardiac output. So in somebody with low oxygen consumption, so in this area, for example, the cardiac output is also going to be low. But in somebody with higher oxygen consumption, the cardiac output is also going to be high. So it's like a linear relationship. So in somebody with a low oxygen consumption, for example, somebody's always lying in bed, they're going to have a lower cardiac output and lower cardiac index. An athlete, on the other hand, is always running, exercising, whatever, and they have increased oxygen consumption, and that is going to cause an increased cardiac index. Okay, remember this equation? Cardiac output equals to mean arterial pressure over total peripheral resistance, okay? This is just a rearranged version of arterial pressure equals to cardiac output into total peripheral resistance, okay? This is just the rearranged version, nothing different. So what happens if my arterial pressure is constant, okay? For example, equals to 1. So cardiac output equals to 1 over total peripheral resistance. Okay, so if my total peripheral resistance is increased, I draw an increased arrow here. That means that my cardiac output will decrease. And vice versa. If total peripheral resistance is decreasing, cardiac output will increase because they are inversely proportional. And this is where it applies to. In pathological cases, for example, in cases with low total peripheral resistance, we talked about beriberi, remember? When there was massive peripheral vasodilation, okay? Massive peripheral vasodilation and massive peripheral decreased total peripheral resistance, okay? All of the blood was pooling in the feet. That means the heart has to work harder, okay? It has to have a higher cardiac output. Let me put the equation for you again. Cardiac outputs equals to 1 over, TPR. So in beriberi, total peripheral resistance is decreased. That means cardiac output will increase, and it might cause high cardiac output failure. Same thing with AV shunts, actually. An AV shunt is basically when you take an artery and you take a vein, and normally blood goes from arteries to arterioles to capillaries to venules to veins. It's a long process, right? And the high blood pressure eventually transforms to low blood pressure. However, in AV shunts, you completely bypass all these capillary beds and everything. You bypass all of that. You directly connect the artery to the vein. That means if there's high pressure in the artery, it's going to directly go into the vein. So the vein is also going to have a high blood pressure. And how would that decrease total peripheral resistance? That's because you completely eliminated everything. You eliminated all the capillary beds. They're gone. There's no resistance. So if you have like low total peripheral resistance, that means the heart's going to have to work harder. That is why you have AV shunts. In hyperthyroidism, you have high cardiac output. Anemia, anxiety, pulmonary disease, Paget's disease, you have to know all of these by heart. In cases with high total peripheral resistance, for example, people who have hypertension, who have valve diseases, who have experienced heart attacks or shocks, or those who go into cardiac shock, they're going to have increased total peripheral resistance and a low cardiac output. Okay, so remember this. This is just a diagrammatic explanation. Now, if you look at this graph over here, the control is young adults. Okay, so cardiac output here is 100%. So here the cardiac output is increasing, and here the cardiac output is decreasing. So above 100%, what do we have? The highest one here is beriberi. So beriberi has a high cardiac output. Then you have AV shunt, hyperthyroidism, anemia, anxiety, pulmonary, pregnancy, Paget's disease. And then you have the control. This is 100%. Below 100% is when you have decreased cardiac output. So you have hypertension and then valve diseases and shocks and myocardial infarctions. This is the same exact thing, different format. So 100% cardiac output. Above it is increased, so you have beriberi AV, hyperthyroidism, anemia, pulmonary Paget's. This is the normal. Below normal, you have less cardiac output, you have removal of both arms and legs, and hypothyroidism. Okay? Now I want to talk about pressures so that we can move on to our lovely venous curves. Normal right atrial pressure is 0. Okay? I mean, it's a range of values from like 0 to 4, but in your lectures, especially for the 18th batch, you have to know that the normal right atrial pressure is 0. Okay? So if you look at this equation, this looks like a new equation to me. I have cardiac output equals to mean arterial pressure minus right atrial pressure over total peripheral resistance. I've seen this before. I've seen this before. And I've seen this before. Okay? And I also know that right atrial pressure is 0, right? Normally. So if mean arterial pressure minus 0, that means that just remove it. It's 0. So that gives us the equation cardiac output equals to mean arterial pressure over TPR. Okay, this is the equation that we've been using all along. But what happens if the right atrium pressure is not 0? It means we can't remove this. We can't just kick it out because it's an actual value. And that's what we'll talk about in a bit. So normally, okay, forgot to address the elephant in the room. This is the cardiac output graph. Okay. Normally, the right atrial pressure is 0 and the cardiac output is 5 liters. So if you want to read this graph, let's start with the normal. Okay, let's start with the right atrial pressure being 0. So this is 0 here. Go up, up, up to the normal green graph. Turn left. You can see here that the cardiac output is 5. Okay, that is exactly what it says here. At a right atrial pressure of 0, cardiac output is 5. What happens if the right atrial pressure increases from 0 to 2? Okay, so between 0 and +4, you have +2. So if it increases to +2, I'm going to go up, I'm going to go up, I'm going to go up, oh, keep going up, and then I go left once I touch the graph, and it's like 12. Okay, that means the cardiac output has increased. So if my right atrial pressure has increased, that means my cardiac output has increased. Why is that? Okay, this is very important. Okay, first of all, you have the Frank-Starling law of the heart. The Frank-Starling mechanism is that when you have increased venous return, okay, that means a lot of blood is in the vena cava. All of that blood is going to the right atrium. Okay, when it goes into the right atrium is stretching. All of that blood is going to be pumped into the right ventricle. The right ventricle walls are going to detect the stretch. They're going to be like, whoa, why are we stretching so much? And that's going to do what that's going to do is that it's going to increase the contractility of the heart. So Frank-Starling law is always associated with contractility. Okay, so increased stretch of the walls is going to increase contractility, and the blood is going to be pumped out harder. So increased cardiac output. Okay. Same factor here is the Bainbridge reflex. That's not the same, it's a different one, but they're very similar. So when you have increased venous return, the SA node, which is located in the right atrium, is going to be stretched. And also the atria are going to be stretched. So the Bainbridge reflex is when the atria is stretched, the sympathetics are going to be activated. Sympathetics are activated, which means that contractility and the heart rate are going to increase. So whatever mechanism, Frank Starling, Bainbridge, whatever it is, if the right atrial pressure increases, that means the venous return has increased, which means the cardiac output will also increase. Okay, diagrammatic. Venous return increased. Atria stretched more. Bainbridge reflex activated. Increased sympathetic activity. Increased cardiac output. Easy. Okay, so what happens in a hyper-effective heart? Let's look at the normal first. Right atrial pressure is 0. You go to normal graph, you turn left, it's 5. In a hypereffective heart, I'm going to go to the biggest one, which is this blue one. So I'm going to go up from 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0. Oh, look, it's 10. So add 0. It's not 5. The cardiac output is not 5. It's increased. It's 10 now. And why is that? What are the causes of a hypereffective heart? Hypereffective means that it's working more than it's supposed to. Okay, it's trying too hard. This is because you either have increased sympathetic stimulation. So when you have increased sympathetics, you have increased heart rate, you have increased contractility, which is strength of contraction. Or you have heart hypertrophy. That means that the walls of the ventricles are hypertrophy. There's more muscle mass. Okay, so when there's more muscle, they're going to increase the strength of contractions like that. And that is what's going to cause an increased cardiac output at RAP equals to 0. Of course, when you increase the pressure of the right atrium in the same thing, if it's +2 and you go up again to the hypereffective heart, it's crazy. It's like 22.5, 23, okay? So all the values of the cardiac output, regardless of the right atrial pressure, are increased in hypereffective heart. Now in hypoeffective, the heart is not working. It's literally not working. It's not contracting properly. The strength of contraction is decreased and the heart rate is also decreased. Okay. So this scenario can happen in severe hypertension. It can happen when you have an inhibition of the sympathetics or when you have coronary artery blockage. Remember, coronary arteries supply oxygen to the blood, to the heart. So when you have less oxygen in the heart, it's not going to contract properly. It's going to cause a heart attack probably. Well, other cases, you have valvular heart disease, congenital heart disease, myocarditis, and hypoxia. You need to know all of these. So let's look at the graph again. Look at this bottom hypoeffective thingy. 0, it's supposed to be 5, but here it's like 2.5. Okay, that means the cardiac output is greatly reduced. The heart's not working. This is the lowest one. So I'm trying to go up. I can't even go up because it's literally like one liter per minute. And that's severely low. That's hypoeffective heart. Okay. Very easy graph. This is from another lecture, same lecture, but like from last year. If you look here, this is a normal, this is a normal cardiac contractility curve. Okay. Cardiac function curve, sorry. Hypereffective means that the curve is displaced upwards. And hypoeffective, the curve is displaced downwards. Just remember this. And you can learn. Just read this. Okay? Next, you're going to practice. If you want to practice, it's going to be good for you. So just remember the general shape, okay? It's going to go like this. In hypoeffective, it's going to be lower. And in hypereffective, it's going to be higher. Next, let's talk about venous return. So venous return is basically all the blood that returns to the right atrium, okay? Here you can see it says mean systemic filling pressure. So mean systemic filling pressure is the average pressure in the systemic circulation when the heart stops and blood redistributes evenly. So if your heart stops, God forbid, all the blood is going to redistribute evenly throughout all of the blood vessels. That filling pressure the filling pressure of the blood is called the mean systemic filling pressure. Or you can look at it from another perspective. So when the heart pumps the blood out, so you have blood pressure 120 over 80. Okay, so systolic over diastolic, whatever. So this blood pressure is going to travel all across your body. And at the end, the pressure is going to go down because it's traveled so much. the pressure is going to be lost. So at the very, very end, when blood is entering the right atrium, the blood pressure in the superior and inferior vena cava is going to be +7. So it's dropped from 120 to 7. So this is even though it's very low, it's not 0, it's still 7. However, as we learned before, the right atrial pressure is 0. Okay? As a rule of thumb, blood is going to flow from high pressure to low pressure. So if right atrial pressure is 0, vena cava 7, it's going to flow from 7 to 0. Okay? What happens if I increase the vena cava pressure to 10 and right atrial pressure remains 0? This means that we have a greater pressure difference, a greater pressure gradient. That means there's going to be more blood flow from the vena cava to the right atrium. If the vena cava pressure drops to, for example, 3, and right atrial pressure is still 0, what will happen? Blood flow will still happen, of course, because this is high pressure and this is lower pressure. However, the blood flow is going to be less compared to 7 and 0 because, of course, 3 and 0 is a smaller pressure gradient. Okay? Now, a very interesting case is when vena cava pressure is 0, so mean systemic filling pressure is 0, and right atrial pressure is also 0. They're both the same. They're both 0. What happens? If they're both the same, there's going to be no blood flow at all. Okay, so if they're both the same, there's going to be no blood flow. So this is very important to remember. Okay, so this is just a written version of venous return. Now, vascular function curve. First of all, I want you to look at the axis. So on the x-axis, you have right atrial pressure. So it ranges from -2 to 9 on this axis, and you have venous return, which ranges from 0 to 9. Okay. The mean systemic filling pressure here is 7. So if you want to look at what the mean systemic filling pressure is, you go to where this curve ends on the x-axis. Right atrial pressure here, it ends at 7. This is the mean systemic filling pressure anywhere. Okay, so just remember this. Now, normally we learned that right atrial pressure is 0, and when it is 0, the mean systemic filling pressure is 7. And in those conditions, the venous return must be 5 liters per minute. However, in this graph, you'll notice that it's not 0, it's like 1.5, but ignore that, just pretend it's 0, okay? We're gonna focus on the shape of this graph. So let me erase all of this. Okie awesome sauce. Okay. Now, we established that mean systemic filling pressure normally is 7. And right atrial pressure is 0. Okay, that means the blood is going to flow from the vena cava into the right atrium. However, if the right atrial pressure is 7 and the mean systemic filling pressure is also 7, what did we say would happen if they were both the same? There would be no blood flow at all. Okay, so there would be no venous return, which is what you can see on this graph. If the right atrial pressure is 7, venous return is 0. Okay, as the right atrial pressure decreases, for example, it becomes 5, venous return also increases. So 5, and then you go left, you can see it's like 2. Okay, at right atrial pressure of, for example, 3, venous return has increased until it reaches a limit. Okay, so venous return, the maximum venous return normally is 5 liters per minute because cardiac output normally is 5 liters per minute, and in normal circumstances, cardiac output equals venous return. Okay, so if it's 5, it should be 0, but then you just know the shape of this curve, okay, and just know that you have mean systemic filling pressure over here. Now let's look at what factors affect this curve. So if you have increased blood volume, if you take a person and you inject a lot of blood into him, or if you have decreased venous compliance, means that the venous tone is high, means like the big veins are constricting like this. Or if you have decreased arteriolar resistance, you have vasodilation of the arterioles. That is going to increase the venous return. Okay, and this is very confusing. So let's look at it from we'll come back to this slide. Let's look at it from the diagrams. So what happens when the mean systemic filling pressure increases? which means that when more blood enters the circulation, okay? So if you have more blood entering the circulation, that means your venous return will increase because your mean systemic filling pressure is also going to increase. That means that your vascular function curve is going to displace upwards like this, okay? That is the case. And this is way easier. If you have an increased blood volume, you have an increased change in pressure between the two, and then you have an increased venous return. So you can see here that this is the normal function curve, and if you have increased blood volume, the graph displaces upwards. If you have decreased blood volume, the graph displaces downwards. And notice that the mean systemic, what's it called? Mean systemic filling pressure also changes. Okay, so just know these two things. So what happens when venous compliance decreases? Okay, what is venous compliance? Venous compliance is like the veins are very compliant, means that they're very relaxed. They're going to do whatever you want them to do. However, when the venous compliance decreases, okay, that means the veins are going to constrict. Okay, and when those veins constrict, the big veins, the vena cava, whatever is returning the blood to the heart, when they constrict, all the blood is going to shoot upward into the heart. Okay, and that is what's going to cause displacement of the graph upwards. So again, decreased venous compliance, okay, means that increased veno-resistance is going to cause all of that blood to go into the heart. And when you have all that blood going to the heart, that means you have an increased venous return, okay? And that means your graph is going to be displaced upwards at a higher level. If you have an increased venous compliance, that means your veins are very compliant, okay? They're not resisting at all. That means all the blood is pooling into the veins. So when all the blood is in the veins, there's nothing going back to the heart. That means your venous return has decreased, okay? And the graph shifts downwards. Now, this is a very, okay, but it won't load. Let me load that again. Seconds. Refresh, maybe. It should work. Okay, awesome. Now, if you have a look-see here, increased arteriolar resistance or increased arteriolar tone is going to cause a decreased venous volume, which is going to cause a decreased venous return. Okay, what does that mean? That means that when you have arterioles, okay, these are arterioles, okay, and then you have all these capillaries, okay, so 1 capillary, 2 capillary, 3 capillary, 4 capillary, and then you have big veins, okay, so big, huge veins like this. Now, blood is coming through here, through the arterioles. If these arterioles are going to constrict, their resistance is going to increase. That means less blood is going to flow into the veins, right? So if you constrict the left side of the heart, if you constrict the arterioles, then less blood is going to go into the veins. And if less blood is going to the veins, then less blood is going to return to the heart. That means your venous return is going to decrease, okay? That is what's shown over here. So if you have an increased arteriolar resistance, okay, it's going to cause a decreased venous return. So it's going to displace downwards. However, if you have a decreased arteriolar resistance, which means that arterioles are going to expand, that means you're going to allow the blood to come from the arteries into the arterioles, into the capillaries, and into the veins. That means the venous volume is going to increase. That means venous return is also going to increase. So you're going to have an upward displacement of the curve. Okay? Now you might think, hold on, something's off here. Over here, we notice that the mean systemic filling pressure has decreased and increased. But in the case of arteriolar resistance, the mean systemic filling pressure remains the same. Okay, this is very important. So mean systemic filling pressure is the same regardless of arteriolar resistance changing. Now, this is a summary of the curve. So you have changes to vascular function curve reflect changes in blood volume. So if you have increased blood volume, you have increased venous return. If you have decreased blood volume, you have decreased venous return. Then you have venous compliance or venous tone. Okay. If there is decreased venous compliance, means the veins are not compliant, they're restricting. That means you have increased venous return to the hearts. However, if they're very compliant, you have an increase in venous compliance. That means the blood is allowed to stay in the veins. It's not going up. That means the venous return is going to decrease. Then you have arteriolar resistance, okay, which we just looked at. So if you have increased arteriolar resistance, that means that they're not going to allow the blood to go into the veins. That means your venous return will decrease. If you have a decreased arteriolar resistance, that means the arterioles are expanded. Blood goes from the arteries through these expanded arterioles, through the capillaries, and into the veins. Venous return is going to increase. And where does mean systemic filling pressure remain the same? In cases of arteriolar resistance. Okay, question time. A 30-year-old man is resting and his sympathetic output increases to maximal values. Okay, so maximal values is a key word here, which means that sympathetic is affecting both the heart and the vasculature. Okay, which set of changes would be expected in response to this increased sympathetic output? Pause and think. Okay, so when you have increased sympathetic output, okay, that means it's maximal. The sympathetics are affecting everything. And what is the effect of sympathetics on the blood vessels? They're going to contract. So even in veins, if there's sympathetic output to veins, they're going to contract. And when you have an increased veins, like when you have an increased, what is it called? When your vena cava and your larger veins are contracting, okay? That means all of the blood is being pushed into the heart. Okay, what does that mean? That means that you have an increased mean systemic filling pressure. Okay, so you have this one. Because, see, sympathetics not only act on the arteries, they also act on the veins, right? And if they act on the larger veins, that means the blood is not allowed to stay in the veins. It's supposed to go up. That means the mean systemic filling pressure also increases. So it's either this one, or this one, or this one, or this one, okay? Now, resistance to venous return. Now we said that sympathetic applies to all arteries and veins and everything, right? So it would also apply to the arterioles. Now, if the arterioles are affected, they're going to vasoconstrict because of sympathetic. So when they constrict, that means the blood is not allowed to grow from the artery into the veins. So that means you have less blood in the veins now. That means you have increased resistance to venous return, okay? So it's either A, or it's B, or it's C, or it's D. Okay, so what's matching here? A is matching, okay? Of course, we said that venous return would increase. Now, let's look at it a bit more refined. The answer is A. So venous return equals to mean systemic filling pressure minus the right atrial pressure over resistance to venous return, okay? I'm not going to go into the details of the derivation of this equation, but just know this equation for venous return, okay? So in max sympathetic output, you also have MSFP increase, and you also have resistance to venous return increase, which means that you have venoconstriction of the large veins, and you also have constriction of the arterioles. However, the venoconstriction is way more than the arteriolar constriction, okay? So MSFP is more than this. Okay, so that means your venous return is going to increase. Next, we're going to combine the cardiac output and the venous return graphs. Okay, so this is a venous return graph. You can see here, it starts over here and then it goes downwards. And the cardiac output graph always has this sigmoid shape like this. So this is the cardiac output graph. The equilibrium point is important to know here. At a right atrial pressure of 0, okay? your cardiac outputs and your venous return both are 5 liters per minute. This is very important to note. And your mean systemic filling pressure is 7. So let's go to the very, very exhausting graphs. I know this looks crazy, but bear with me. So you have 4 versions of the venous return graph, and you have 4 versions of the cardiac output graph. Okay. Now the normal ones are the red ones. Okay, just keep this in mind. This is the normal one, and this is normal venous return graph. You can see here, right atrial pressure at 0, it's 5. Cardiac output and venous return are 5. What happens when you have a sympathetic stimulation of the heart? Okay. I'm talking about the heart only. I'm not talking about the venous return. I'm not talking about the vessels. I'm talking about the heart. When you have sympathetic stimulation, the graph is going to shift. Okay. So the cardiac output graph is going to shift upwards. Okay. And when you have maximal sympathetic stimulation, so you have more sympathetic stimulation, it's going to shift even higher up. Okay. However, when you don't have sympathetic stimulation, when you have spinal anesthesia, okay, in cases of spinal anesthesia, the graph, the cardiac output graph drops, okay, and the venous return graph also drops. So you have depression of both. This is very important to remember. This was in the slides. So I want to draw this out for you. This is the graph, okay, and this is the normal. This is the normal cardiac output, and this is the normal venous return, okay? Now, in cases of, where can I change the color? Right. So in cases of spinal or general anesthesia, okay, the cardiac output is going to, it's going to decrease. The venous return is also going to decrease. So this is going to be the new thing. This was mentioned in the transcription, so you gotta know this one. There's an easier version of this graph. So we're gonna go to that one, which is this. Okay, this is labeled for you. Again, on the x-axis, you have the right atrial pressure. And on the y-axis, it's either the cardiac output or the venous return, same thing. So the normal thing is over here. This is the star is the normal. Okay, so you have, if you follow this, the middle line, this is the resting cardiac curve, and this is the resting vascular curve. Okay. What happens if the contractility of the heart increases? I'm talking about the heart. That means you have to focus on the cardiac curves. So either it's this one or this one or this one. So this is the normal one, right? Resting cardiac curve. If you increase the contractility, the curve is going to go upwards. If you decrease the contractility, the curve is going to go downwards. Okay, this is for the heart. See, if you take all these things step by step, they're not difficult at all. If you look at this graph, suddenly you're going to be overwhelmed, of course, but remember to always do things step by step with these graphs. Okay, now let's look at the resting vascular curve. What happens if there's a blood transfusion? Okay, we talked about this. That means the whole graph, this whole resting vascular curve, is going to be displaced upwards. So you can see here, it's displaced upwards, increased volume and decreased venous compliance. Okay, and remember here, the mean systemic filling pressure is also increased. Now, what happens if someone loses a lot of blood? Okay, God forbid they get into an accident, they lose a lot of blood. The volume of the blood is going to decrease. Okay, that means we're going to go to this curve over here. Okay, and voila. So resting vascular curve, increased volume and decreased volume. In decreased volume, again, see the mean systemic filling pressure also decreased. So that's that. And now for the second part of the venous return graph. Okay, so this is the resting vascular curve. If you have increased arteriolar tone, it's going to shift downwards. If you have decreased arteriolar tone, it's going to shift upwards. Okay. So what happens if the sympathetic nervous system activity, so the veins only, increases? Keyword veins only, keyword sympathetic. So sympathetic means, what does it mean? Okay, so pause and think about this. So sympathetic means that the venous constriction is going to happen. So remember when I said that when sympathetic stimulation happens, it's not only going to affect the arterioles, it's also going to affect the large veins, the vena cava and whatnot. So you're going to have an increased venous tone, okay, of the vena cava. So the vena cava is going to constrict like this. And what that means is that all the blood is going to go from the venous system into the heart. And that means your venous return is going to increase, right? So this is a normal cardiac output graph. So we're not going to change that, but we're going to change the venous return. So venous return is going to go from this graph to this graph because the venous return has increased. So we have F. So what happens if sympathetic nervous system activity to the arterioles is decreased? In this case, you have a decreased arteriolar tone. Because remember, sympathetic acts on all the blood vessels. So if it's going to decrease on the arterioles, means the arterioles are not going to contract anymore. They're all going to dilate. And when the arterioles dilate, they're going to allow the blood to pass from the arteries into the veins. That means your venous return is going to increase, right? And remember that for the arterial graph, it's this one. The one that has the same mean systemic filling pressure. So the answer is G. Okay, so G. What happens if we administer digitalis? Okay, so digitalis is a positive inotropic drug that only acts on the cardiac muscle. It does not act on any of the blood vessels. So what that means is that when you look at this venous return curve here, you don't have to worry about the rest of them. You just have to focus on the contractility curves because digitalis only acts on the heart. And it's positive inotropic, so the contractility will increase, and then the curve will shift upwards, and the new point is point C. Okay, awesome. Now, we have a question. In the figure below for the cardiac output and venous return curves defined by the solid red lines, so these solid red lines over here, as you can see, this is the normal venous curve and normal cardiac output curve. With the equilibrium at 8, which of the following options is true? So A, mean systemic filling pressure is 12 millimeters mercury. No, it's not 12 because if you look over here, the venous curve goes down and it stops here. It stops at 7. So that is wrong. The mean systemic filling pressure is actually 7. It's not 12. So A is wrong. For B, it says right atrial pressure is 2 millimeter mercury. Well, that's wrong too, because if you look here, point A, if you go down, 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 it's actually 0. So the right atrial pressure is 0, not 2. So B is wrong also. Resistance to venous return is 1.4 millimeter mercury per liter per minute. So now you can see we don't have resistance to venous return on this graph. We can't just look at it and say, okay, it's 1.4, whatever it is. We have to calculate it. So for that, we have this equation. Remember, venous return equals to mean systemic filling pressure minus right atrial pressure divided by resistance to venous return. Okay? Do not forget this equation. And also in normal conditions, venous return equals to cardiac output. So that means you can replace venous return with cardiac output over here. So again, cardiac output equals to MSFP minus RAP divided by resistance to venous return. So in this normal condition, we have cardiac output as 5. So we're going to put 5 there. We have MSFP as 7. So we're going to put 7 there. Right atrial pressure is 0. So you're going to substitute 0. So play around with the numbers, you're going to get x equal to 7 over 5, which is 1.5 millimeter mercury per liter per minute. Okay? Now we're going to talk about the effect of opening a large arteriovenous fistula. Okay? Now, that's a mouthful of words, so let's break that down. In patients who are undergoing hemodialysis, what happens is that a large artery with a lot of pressure is directly connected to a large vein. Okay, and what that does is that it bypasses all of these arterioles, capillary beds, venules. It just bypasses all of that. So it bypasses all of this peripheral resistance and just goes from high pressure to high pressure again, because arteries are always at a higher pressure, right? And if you connect them to the veins which were initially at low pressure are also going to become high pressure. So what happens in this case? In this case of a fistula. Now, this looks like a lot, but it's okay. You guys just have to take it step by step. Okay, so the red curves are the normal curves. Okay, so you can see over here, right atrial pressure is 0, and the cardiac output or the venous return is 5. Okay, MSFP is 7. Okay, so just familiarize yourself with that. So immediately after you open the fistula, so immediately as you connect the artery with the vein, what is going to happen? The black dotted lines are the next step. So the cardiac output is going to increase and the venous return is going to increase by a lot. So you can see here that this is the initial venous return. And right after you put the fistula, it's going to increase by a lot. Okay, and the cardiac output, which was initially this red one, also increases. Now, why is that? That's because when you connect this, all of this blood that was going in the artery goes to the vein and it is going into the right atrium. Okay, so in the right atrium, there's going to be more blood. The mean systemic filling pressure is going to be the same. Okay, so don't worry about that right now, but the venous return will increase because more blood is going into the right atrium. Okay, so the right atrium is going to expand, the right ventricle is going to expand, the whole heart is going to expand. And what is that going to activate? The Frank-Starling mechanism, the Frank-Starling law, which means that if there is increased stretch of the blood, the ventricles, it is going to increase the contractility. So that means that the cardiac output also increases. Okay. What I want you to note here is that this is immediately after the fistula. And immediately after the fistula, the MSFP is the same. It doesn't increase. However, the venous return increases and the cardiac output also increases. And that the venous return increase is greater than the cardiac output increase. Okay, you should know this. So let me erase this. The eraser. Okay. Now I want to talk about what happens within a few minutes. So the black dotted line was immediately, right? Now, after a few minutes, the sympathetic system is going to activate, okay? When the sympathetic system activates, the mean systemic filling pressure is going to increase. So you can see over here in this brown dotted area, the mean systemic filling pressure increases to above 8, okay? And the venous return curve is also shifted more to the right. So that means the venous return increases. The cardiac output is also going to increase. So you can see here, the brown dotted line, it's going up again. So red to brown, increased contractility, and red to brown, increased venous return. And MSFP is also increased. Okay, this is because you have sympathetic stimulation after a few minutes. And that is where you have point C. Then you have D. D is after weeks. So let's erase this again. All right. So after a few weeks, the sympathetic system is going to reach its maximum effect, okay? Maximum effect. That means it's going to act on the heart. The heart is going to be pumping at its hardest capacity, at its strongest capacity. It has increased rates. Everything is increased, okay? And the venous return is also greatly increased. And also note that the MSFP has increased further. So the green ones are where you have maximum sympathetic stimulation after a few weeks, okay? So at point D, you can see that the cardiac contractility curve is high, it's extremely high. And the venous return curve is extremely high as well, as way to the right. And you can see here that the mean systemic filling pressure is 12 right now. The right atrial pressure is also over here. You can see that after a few weeks, that sympathetic stimulation is the highest. Okay, so I hope that this is very, very clear. This is like a very complicated concept if you look at it like from a fisheye perspective. So like if you're scrolling through the slides and then you come across this, you're going to be like, oh my God, what is this? But really, if you take it step by step, it's going to be very easy for you, inshallah. Okay, so I just want you to remember these points and never forget that immediately after you place the fistula, there is no increase in MSFP. But however, after a few minutes, MSFP will increase because of sympathetic stimulation. After a few weeks, maximum sympathetic stimulation, and you have way more increased MSFP, VR, which is venous return, and cardiac output. Okay? Now, this is a little exercise for you. Okay? It would really help if you guys learned how to draw the curves. Okay, and it's a very simple concept, really. I already drew like the first part of it. So this is the normal conditions. In normal conditions, at 0 right atrial pressure, you have a cardiac output or a venous return of 5. Okay, so this is the normal. So what happens if I put on the fistula? Okay, let's go through this again one more time. If I have the fistula immediately after, okay, you're going to start through here because the MSFP is the same immediately after. So the venous return is going to increase. It's going to increase by a lot, okay? And the cardiac contractility curve is also, it's going to increase. Oops. There we go. It's going to increase, okay? And then after that, I'm going to change the color. After a few minutes, when you have sympathetic stimulation, the MSFP is going to increase. You're going to start here. You're going to, whoa, that's huge. You're going to draw the, let me just erase that because this is a little bit too large. Okay, so after a few minutes, you have sympathetic stimulation. So MSFP is going to increase. You're going to start from here. You're going to go up, 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 up. So that you can see that the venous return curve is higher up. And the contractility curve is also higher up, right? And then at the very end, after a few weeks, when you have maximum stimulation from the sympathetics, you're going to start from here. MSFP has increased to like 12. So you start here and you start drawing your venous curve like this. It is so high up, and the contractility curve has also increased. Okay, so this is your new point D. So I hope that's clear. I want you guys to practice this. Make it very clear about how circulatory dynamics work in this arteriovenous fistula. Okay, so just read this part on your own. And that's it. Thank you guys so much. I tried to include everything in the slides. If I didn't include anything, I'm so sorry. Hopefully everything is enough for your exam preparation. If you have any questions, at all, please do not hesitate to email me. Even if there's something that I didn't mention in the slides, but you come across and it's the same topic, just send them to me and I'll help you out as soon as I can, okay? Please scan this code for feedback, and thank you so much. Good luck for your exams, inshallah. They'll be very easy. Bye.